in the chat during the last 5 minutes. If you would kindly complete this before leaving, it would be much appreciated, and it should only take you about 5 minutes. I'd like to start today's proceedings by handing you over to Glenn, who will talk about elder abuse.
Welcome everybody. As Natalie has indicated, today's session is all about elder abuse. And I suppose we could be asking, why are we focusing on elder abuse as a specific topic? Research has indicated that 1 in 6 older people are victims of abuse. And that's over 16% of our mothers, fathers, uncles, aunties, grannies, granddads, friends and neighbours. And to make it more realistic, for me, I have a circle of 23 individuals who are categorised as being elderly. And in that, I have to count myself and my husband in that category. So out of those 23, potentially 3 or 4 of those close relatives and friends could be victims of elder abuse. So if you think of your own circle of friends of that specific age group, how do you know, how do we know that they could be potentially victims of abusive actions? Next slide, please. So the aims of today's session are to identify by what is meant by the term elderly and the term elderly abuse, the 7 types of elderly abuse, and the risk factors and warning signs. We also hope to learn from an adult safeguarding review and apply this to a case study later on in today's session. We will revisit what professional curiosity looks like in practice. What are the barriers and the importance of language that we use to not only the victims, but also other family members? To have a recap and discuss what the future looks like in respect of adult safeguarding, particularly around elderly abuse. And also to have the opportunity to share good practice and practical tips. Next slide, please. So this slide shows a well-known optical illusion. It's titled "My Wife and My Mother-in-Law." And it's a famous optical illusion that depicts both an old woman looking off to the left and a young woman facing away, looking over her right shoulder. Researchers identified that the person you see first is affected by how old you are. And this is according to a new study that was recently published in the Scientific Reports. So what do you see? And for me, this really applies to how we see the elderly in our community. Are they hidden, or are they there to be seen but not seen? So each image requires a change in perspective. And today's session will look at how we can shift our perspective to better understand and identify elder abuse. What does it mean to be elderly? As you see on the slide, the Oxford Dictionary defines elderly as old, having lived for a long time, no longer young. And the NHS defines elderly as someone over the age of 65. That's me. And in a way, it almost puts me into, I won't say a box, but into a category where I'm not viewed perhaps by some as an individual, but as being an elderly person in their care. Be interested to know what your thoughts are on that. Next slide, please. This is for Emma.
Okay, so I'm going to be taking you through the 7 types of elder abuse. And those are physical abuse, sexual, emotional, financial exploitation, neglect, abandonment, and self-neglect. Abuse can be perpetrated by anyone, and the abuser of a vulnerable adult could be someone already known to them, such as a paid caregiver, a family member, or a friend. Older victims' experiences are often made worse by social, cultural, and physical factors. Romance scams and predatory marriage are quite common in the elderly as well. Next slide, please. For the signs of elder abuse: patterns of bruising resembling fingertips, symmetrical patterns of bruising on both sides of the body, bruises, cuts, or abrasions on wrists or ankles, unexplained bruising or bleeding from the lips, cheeks, face, or head, and bruising in odd places, such as the abdomen or underarms. Signs of sexual abuse in the elderly could be bruising around breasts, buttocks, or thighs, bruising or tearing around the genitalia, unexplained bleeding from anus or vagina, ripped or bloody underclothes, unexplained venereal disease or infections or recurrent infections, and the individual stating or hinting that abuse, including unwanted advances, has occurred. Odd interactions between the individual and possible abuser, such as the individual appearing tense or uncomfortable with another person's touch, or another resident in a residential setting, seeming somehow a little bit too close and intimate. Sudden changes in behaviour, such as becoming more nervous, more jumpy, aggressive, or withdrawn, difficulty sleeping, or unexplained sudden weight loss, hostility or frustration in a relationship between an individual and a carer. Next slide, please, Natalie. Financial abuse in the elderly could present itself as unexpected eviction notices or utility shut-off, unexpected bills or unpaid bills, or unusual spending patterns, unnecessary services or subscriptions to new purchases, and cash or items of value going missing. So items of, like small items of jewellery, is very common to go missing. Suspicious changes to wills, property titles, and other legal documents. Suspicious bank withdrawals, unexplained sort of large sums of money, or even sort of small regular withdrawals from a bank account that can't be explained and that the elderly person has no access to. The duplicate billings for services or billings for services not rendered. The signs of neglect within an elderly person's world. An unkept appearance, such as messy hair and clothing, just being unclean, poor body odour. Home appears unclean or unsafe, could be cluttered and cold. Dressed inappropriately for the weather. So it might be a really cold, frosty day, and someone is sort of an elderly person is wearing a summer dress and sort of no tights and just looks, you know, really cold on a really cold day. Not using or wearing sort of medical appliances, hearing aids, like a foot brace or other sort of medical device. Maybe not wearing dentures. or a hearing aid, just affecting those sort of items that can improve their quality of life not being used. And evidence of medications being taken inappropriately, such as having too many pills over at the end of the month or not having enough. So pressure area damage, bed sores, or signs of inadequate care, wearing soiled incontinence pads, and possibly wound dressings not being changed and increasing the risk of infection. Next slide, please. So emotional, sometimes also referred to as psychological abuse, includes emotionally distressing activity, such as yelling, threatening, intimidating, ignoring, or using hurtful words. It can include isolating the elderly person from their friends or their family members. Abandonment. This is a severe form of neglect, and it occurs when a caregiver has assumed responsibility for care or custody of an elderly person and then leaves them without arranging appropriate replacement care. Sometimes due to a change in circumstance, stress, or financial reasons, the elderly person is abandoned. Self-neglect. Elder self-neglect occurs when an elder fails to meet his or her own needs. Self-neglect may be a result of dementia, depression, or other physical or mental health condition that makes it hard for them to realise or meet their own needs. Often complex and very challenging for healthcare professionals who are trying to reach out. And many people who self-neglect can't see that they are self-neglecting. Next slide, please. So factors that increase the risk of elder abuse. Poor health of the older person, such as poor physical health, poor memory or dementia, poor mental health or mental illness. Preparedness or state and well-being of the caregiver. So maybe a lack of understanding of the older person's condition, of their needs, and a lack of competence and skills to deliver a good quality care for that person. Relationship challenges. So such as a family history of abuse or violence, or sort of past or current volatile emotions, and poor social support. Living arrangements. So this may be, a closed culture of a care provision, or someone living in a very isolated situation. Financial challenges. The elder and caregiver living together may be financially dependent upon each other, and there are limited funds. So risks unique to care providers. There are many: care fatigue, stressful working conditions, poor training, poor leadership, lack of staff, so there are work pressures, and lack of support, working too many hours, and working in a closed culture. Thank you, Stacey.
Thanks, Emma. Okay, so the previous presenters have discussed the different types of abuse, the possible perpetrators, and the sources of risk. So moving on, what do we actually know about the current picture of elder abuse? This graphic that you can see on the screen has been taken from the World Health Organization and the UN's Decade of Healthy Aging, which really highlights that abuse of the elderly is a hidden problem. So globally, abuse of older people is expected to double over the next 30 years. So it's going to increase, or is predicted to increase, from an estimated 1 billion, which was in 2019, to 2.1 billion by 2050. However, what I found when I was researching for this section of the webinar and then discussing with others is that data and intel in this area is really very limited, so it's difficult to get an accurate picture. There are a lot of surveys, there are many studies about abuse and domestic abuse, but they don't routinely include information and statistics on people over the age of 60. And then this reinforces that false assumption that abuse doesn't exist for the elderly person. And you can also see here that rates of abuse increased quite significantly during the pandemic. So nationally, you can see here a graphic which was taken from a Safe Lives report, which was in 2016. So again, it found and highlighted that abuse of the elderly is largely a hidden issue. They found that in the previous year, approximately 120,000 people aged over the age of 65 had experienced at least one type of abuse. They are 44% more likely to also experience that abuse from a family member. But again, accuracy of the data is really important. So what we know, this is what we know about from the data that we do have, but the data and the statistics aren't routinely collected for people over the age of 60. And that which is collected at the moment is only collected on people up to the age of 74. The other graphic there illustrates that you can see for Section 42 inquiries, the greatest proportion of people currently involved in those inquiries are over the age of 82. As a whole group of people that are not known about, because information about this age group isn't gathered. There is a small piece of information there on the local scale of elder abuse, which is that 10% of older people are likely to experience some form of domestic abuse, and that is increasing. However, I wasn't able to find other data information for other areas of the South West. And then lastly, why is elder abuse underreported? So there are many factors which deter older people from disclosing abuse. Many of those factors faced by the elderly are also common to everyone who does experience abuse, but an older person's experiences are often made worse, as mentioned earlier, by social, cultural and physical factors. So one of those is dependency. Older people are more likely to have health problems, reduced mobility and other disabilities, and this then increases their vulnerability to harm. They're twice as likely to be living with their abuser and then rely on them for care. Another barrier is that there are less opportunities to speak to people that are experiencing abuse, and this has a big impact because disclosing abuse is much more likely to occur if that person has a repeated opportunity to do so. And there's also a greater effect on the older person because they're also less likely to self-refer services that are available, so they are then very reliant on the people involved in their lives and other professionals to then be aware of and recognise any signs of abuse. However, spotting and challenging abuse in the elderly can be difficult. Abuse can be masked, it could be misinterpreted. People and professionals could see presenting issues as being an age-related condition. So bruising could be linked to medication or an ailment, when instead it's physical abuse. Depression and confusion could be a sign of psychological, emotional abuse or coercive control. Abuse can also be confused with carer fatigue. Psychological and financial abuse is actually recorded as the most common form of harm, which includes manipulation of older people to obtain their assets. So that could be through predatory marriage, wills, and then abuse of power through the lasting power of attorney process. Lastly, and what I think is most important and the biggest barrier, are the attitudes towards the elderly. So a recent survey, which was commissioned by Hourglass in 2020, looked at attitudes towards abuse and neglect of older people across the UK. And that survey then found that 1 in 3 people don't believe that inappropriate sexual acts directed at older people counted as abuse. Nearly a third didn't view pushing, hitting or beating an older person as abuse. And also nearly a third didn't see taking precious items from an older relative's home without asking as abuse. I'll now hand back to Emma.
Thanks, Stacey. So, since 2020, in Somerset, there have been at least 4 domestic homicide reviews relating to victims over the age of 60. 2 homicides and 2 suicides related to domestic abuse. The significant other, or the person causing harm, in these cases was a spouse. In the homicides, 1 was male, 1 was female, and in the suicides, 1 was male and 1 was female. Learning from these reviews highlights the importance of understanding the complexities of different relationship dynamics. From the learning review, you can see above with the 7 points. It's about Kathleen, who was a 75-year-old lady, and her adult grandson lived with her. Kathleen had some long-term health conditions, and Kathleen experienced domestic abuse from her grandson. There was also alleged domestic abuse between her grandson and his same-sex ex-partner. It's clear that the domestic abuse between Kathleen's grandson and his partner led to Kathleen being more at risk due to living with her. Kathleen also expressed fear to professionals about this, but this wasn't taken seriously, and lessons were learnt. Next slide, please, Stacey. So learning from reviews. The increase in public awareness that the definition of domestic abuse includes family members aged 16 or over, as well as those who have or are intimate partners. Sharing information across geographical boundaries, agencies to be aware of necessity to share relevant information with their equivalent agency when they are aware of a perpetrator or victim moving to a new area. Inclusion of GPs in MARIC. GPs to be enabled to be part or to contribute to the MARIC process. And MARIC's a multi-agency risk assessment conference. Professionals must be aware that whilst we use the term self-neglect to recognise specific types of behaviours, many individuals won't regard their behaviour in that way and may consider such behaviour as the only way of exercising agency and asserting their sense of self. Professionals have found to be dismissive of concerns around elder domestic abuse, suggesting that victims have lived with abuse for many years and their risk for significant harm is assessed as being low. The NHS is the one service that almost all victims of abuse will encounter at some point in their lives. Thanks, Stacey.
Thank you, Emma. So this is an image that you may have seen before. So it's the power and control wheel, which was developed in the 80s after talking to victims of domestic abuse about what it's like to live with an abusive partner. This wheel's really impactful because it represents the lived experience of those people, and it's a really useful tool to then explore signs of abuse in other areas of life where somebody may be vulnerable to abusive behaviours or where they're experiencing abuse but they don't recognise it as such. So the wheel can be adapted. So, for example, it does describe behaviours that might be used in other settings. It's not restricted to being used solely or referring to intimate partners, as abuse could be perpetrated by a family member, a professional, could be staff on a hospital ward or in a residential setting. Language is really important. So what we've seen in media coverage of older people being abused by workers or family members are that similar tactics are used. So, for example, humiliating somebody who's been incontinent, telling them that they're a burden, that they're making the worker or carer's lives difficult, they're not capable of making their own decisions. So you might wish to use this as a prompt to consider whether what you've been told or what you observe is abuse. And also, as I mentioned earlier, it might be used to help somebody understand that those behaviours are abusive. I'll now hand over to Natalie.
Thank you, Stacey. Thank you. So abuse is not just domestic abuse, although it's abuse most commonly discussed in research. Let's take a look at this case study. Anne is a 72-year-old lady. She lives in a nursing home funded by the local authority and has dementia. Her husband and daughter have power of attorney for health, welfare, finance and property. A safeguarding concern has been raised due to Anne being identified with a severe injury to her thumb, which required hospital treatment. The injury was a fracture and a partial amputation. The injury had little explanation and the family were concerned about the response from the nursing home. There was a 3-hour delay in the nursing home providing any pain relief following the injury. The family were not also contacted until this time, which didn't allow for them to be involved in the decision making regarding Anne's care and treatment as a POA for health and welfare. Further to this, when assessed by medical professionals, Anne was found to have unexplained bruising to her right wrist, a bruise to her right buttock, and a small skin cut that appeared to be from a nail. We have to ask ourselves, what are the safeguarding concerns in this case? What would we be concerned about? And what abuse may be occurring? Physical abuse, neglect, acts of omission? Why is this happening and what will we do to help Anne? Next slide, please. So, moving on. Sorry, mine has just stalled. This illustrates how we as a society treat older people with our care and support needs. So looking at what the outcome was, the concern was accepted as needing a safeguarding response and a Section 42 inquiry under the Care Act 2014. The safeguarding social worker worked in partnership with multiple agencies, including health, police, and the CQC. Anne's well-being was at the centre of the inquiry. The impact to Anne was considered, and while she lacked capacity, the social worker still visited to meet her and observe her to ensure her safety in the home whilst the inquiry was carried out. Anne's voice was also captured through talking to her husband and daughter. Their thoughts, concerned, desired outcomes were asked for and included as part of the inquiry. Anne is now living in a different nursing home. She's settled in well and is happy here. She's putting on weight and looks less frail. Anne's family say they feel they can trust that Anne is receiving the care she requires and are grateful for the support that's been provided. This highlights the reliance we have on care providers to provide the good care, keeping others safe when they're no longer to be able to do this without support. This also highlights that even in a care setting, our elder population are sadly at risk of abuse. And this underlines why education and awareness raising, such as this webinar, is so important. It is vital to raise the profile and spread the word so that society, we work to prevent and avoid harm to older people and they're treated with the respect and dignity that they deserve. Next slide, please. Listening and empowering individuals to speak up. If someone discloses abuse or wanting to talk, let them talk. Actively listen, do not interrupt. Repeat back to them what they've said to ensure you've understood correctly. Know it's okay not to have the answers. Always tell people you may need to let others know what's happening and don't promise anything you can't deliver. And please be proportionate in your response. Some older people may not recognise their experience as abuse and may need some help to see this. Express why you or others are concerned to help them understand why they're experiencing maybe abuse. You will need to consider whether safeguarding duties apply. Is there any reason to suspect the person cannot protect themselves? Is there any cause to doubt the individual's mental capacity and decision-making regarding safeguarding input? Or if they're under any undue influence, coercion or control? Always keep the person at the centre of the decision-making. Be transparent who you intend on sharing the information and with and why. Seek consent where it's safe to do so, and ensure that you record as much information as possible. Take verbatim accounts where possible to help the person's voice to be heard. Different areas will have different support services available. Be clear to the person what the options are if known, or your intention and their consent to making a safeguarding referral. If the situation does not require a safeguarding adults referral and you're not sure what services are available, seek advice from your local authority safeguarding team, who may be able to advise you of the support available in the locality, or provide helplines or support services for the person to engage with. If it's not safeguarded but you remain concerned, your area may have additional guidance on what to do if it's not safeguarding. Information sharing is key, with partnership working providing some of the best outcomes for individuals. Ask yourself, would an MDT be helpful? Ensure the person is aware and consenting to information sharing with others. Who needs to be around the table? Are there any existing avenues in your locality to do this, such as a PCN clinic with multiple agencies in attendance, or does this need to be a separate meeting? In either case, alongside the individual, come up with a plan that may help support the individual's safety or mitigate any known risks. Ensure you document this plan and decision making and continue to monitor the situation. If you are a service providing care or support, consider if there's any new or emerging information that means a safeguarding referral is needed or the risk has changed at all. We all have our part to play to raise awareness. How we can do this within our organisations or workspaces, make use of public-facing information, some of which can be found in the resource sections of the links to this webinar. Discuss it in agendas for team meetings. Provide focus sessions on elder person abuse within your areas using this information to support it. Next, we want to discuss a little about professional curiosity and the role this can play in safeguarding adults, so I'll hand you over to Helen.
Thank you, Natalie. So as we have heard from Stacey, spotting and challenging abuse can be difficult. Emma went on to outline the need to be alive and aware of the whole person and their whole lives to ensure that we are alive ourselves to the signs of abuse. Would like to share a few thoughts with you about professional curiosity and how a lack of professional curiosity may lead to missed opportunities, leaving people open and susceptible to further harm or abuse. In a profession where we work with people, I would pose the question for us all to ponder, particularly those of us who have chosen to work in the profession of health and social care. Why are we not more interested in people? What do we mean by professional curiosity? This can be called a number of things, including respectful nosiness, perhaps. But digging deeper, wanting to know the ins and outs, and in essence, adopting professional curiosity is the way that we, as professionals, have better chance to explore situations with the people we are aiming to support and gain more information and a better idea of the whole picture for individuals and their families. Why is it important? A lack of professional curiosity can lead to missed opportunities to identify less obvious indicators of vulnerability or significant harm maybe. Assumptions made in assessments of needs or risks which are incorrect and lead to wrong interventions for individuals and their families. Presenting issues being dealt with in isolation. Professionals asking questions and seeking explanations from the person, their families, and/or their main carers is something that should be promoted and valued. Healthy challenge is good and can provide assurance that your assessment of a situation is accurate. A high reliance by professionals on self-report by the person, an individual family member, or the person that is caring for them brings with it significant limitations in isolation. and the risk of proceeding on false information. The key to keeping ourselves open to professional curiosity is good information sharing, good quality reflective supervision, and open discussions at key decision-making meetings to check and test information which may be crucial in ensuring that acts of omission, harm, or abuse does not happen. Next slide, Stacey, please. There are a number of things that might get in the way or prevent us from being professionally curious, with some examples listed here. It's important for us to be aware of barriers that can hinder the approach we take with the people we support. By recognising the barriers, we can be mindful of these during interactions with individuals, and we may adapt our approaches to support them better. Information gathering is key in understanding a person's situation, and doing this in a curious way helps to open up communication channels for identifying abuse and disclosure. This is especially helpful if the victim does not recognise their experience as abuse. Motivational interviewing techniques, such as open-ended questions, affirming what the person says, reflecting back to them what they have said, and summarising back to the person so that to make them aware and understand what it is that you have been told. Asking why and repeating why will more reliably take you to the root cause rather than simply considering the effect or impact. Open questions, the 5 W's: who, what, where, why, and when. The TEDS model helps to inform professional curiosity to support health and social care practice. Tell me, explain to me, describe for me, show me. Next slide, Stacey, please. The language and terminology we use may sometimes act as a barrier for older adults, and so we need to be mindful of this and adjust the way in which we communicate with older adults to make our language more accessible, without judgment, and always respectful. I particularly like the question, what would make your life better? This question in itself has the potential to open a conversation and lead to a whole life story that we may need to further unfold. A considered use of language will help and support information gathering and lead to improved outcomes for the older adults we are aiming to support. If we look at these questions, and if you consider these in the circumstances of a domestic abuse situation, a lot of these questions could provide the answers and the narrative to some of the questions stated in the DASH-RIC, Domestic Abuse, Harassment and Risk Identification document. And a DASH risk assessment, additional narrative to support asking these questions to older adults, will be included and sent out or made available with a copy of the slides to participants of this meeting. Next slide, Stacey, please. These questions are provided here simply for reference to aid good practice, and I will give you a moment to read them before handing over to my colleagues as we draw to conclude today's session. Next slide, Stacey, please.
Thank you. So what does the future look like? I hope today's session has given you some food for thought in how we can help our elder population. Age UK has campaigned for data to be collected on all victims and survivors of domestic abuse, whatever their age. And also, if we recall, the Equality Act of 2010 is very clear that age discrimination is not allowed. and that individuals must not be discriminated against because they are a certain age or of a certain age group. So the legislation is there to help us, to help them. This session has hopefully given you insight into the impact abuse can have on individuals. Everyone, all of us, deserves a life free from harm, abuse, and neglect, whatever our age. We know that abuse has a detrimental impact on our communities, to the individuals, and to organisations and services. The emotional, economical, and personal impact that individuals suffer should never be underestimated. So what are you going to do about it? What are we going to do about it? What is the government and agencies doing about it? How do we all collectively recognise the elder abuse that is happening, but nothing perhaps is being done? How do we help those who have perhaps traditionally in our lives helped us? Again, at the beginning of this session, I talked about 16% of our mothers, fathers, and other loved ones are at risk of elderly abuse. And a final thought for all of us. It's a quote from the author Aprana Verma. We need to love and respect old age people because you and I are all aging too. The next slides will provide references for you to be able to follow up on this session. Thank you. Next slides, please.
Thank you, Glenn. That was some very powerful words at the end there. These are the links to the Somerset SAAW website, which you are very welcome to use. The next slide shows the resources we've used to create this webinar. And the next slide is the research papers that we also reference within this webinar. And finally, like all good films, the next one shows you the credits for the presenters.
I'd like to apologise at this point to all of the people on the call to say that I uploaded the wrong version. So actually it doesn't say who Glenn is, and I'm very sorry.
No problem at all, Stacey. I'd like to thank the speakers from Somerset SAAW today for the presentation and also yourselves for attending. Please remember there is a further session tomorrow on domestic abuse. And if you'd kindly complete the evaluation before leaving, it would be much appreciated. Thank you.